Good morning. Today I'm going to talk to you about my best practice recommendation for the triangular fibrocartilage complex classification system and imaging. First, we'll talk about anatomy. The TFCC, which is short for triangular fibrocartilage complex, consists of 8 structures, making it a pretty complex piece of anatomy. First and foremost is the articular disc in the center, and it also includes the meniscal homolog, palmar and dorsal radial ulnar ligaments, extensor colpi ulnaris tendon subsheath, and ulnar capsule, the ulnolunate ligament, and the ulnotriquetral ligament. As you can see here, here we have the radius and the ulna, and it is on the ulnar side. The complex is on the ulnar side of the wrist. The biomechanics of this structure and joint is that it is the main stabilizer on the ulnar side of the wrist. It is responsible for transmitting 20% of the forces that cross the wrist, and its main mechanism of injury is a forced twisting of the wrist, for example, like in a racket sport, or in this example, using a drill if the drill were to get stuck and force the wrist into supination or pronation. Also, another mechanism of injury we see often is falling on an outstretched hand. In 1989, Palmer classified TFCC tears into 2 types. We have the acute type and the degenerative type. The acute tear is obviously from a traumatic injury, and the type 1 tear is an acute or traumatic injury, and the type 2 tear is degenerative. He further subdivided it into where the tears and disruptions were located, and ended up with 9 different sub-injuries. The TFCC disruption is apt to result in a spectrum of damage rather than in the isolation as suggested by Palmer. What's interesting, in his own study done by Palmer, researchers found that only 33% of cases showed an isolated rupture of the articular disc, while the other 67% showed multiple components of the TFCC were damaged, so they may fall in the class 1A or maybe also in the type 1C tear. As far as imaging for the TFCC, we know that X-ray is a standard first go-to when it comes to traumatic injuries. However, the X-ray is pretty terrible at finding a TFCC tear and is rarely used for that. However, what it can do is it can show the ratio, the distance between the ulna and the radius. So here we can see a rather large gap where that TFCC is probably disrupted, and so further imaging is necessary. So what we do is we go on to arthrography. We know that there are a few complications with arthrography, but Schurz et al. Found that it can only detect about 50% of lesions, TFCC lesions, and we can see here, here's where that dye is kind of leaking out of that tear. So it does show that there's something there, but it does miss quite a few. Finally, we talk about MRI. Potter et al. Found that great success with diagnosing the TFCC with MRI. They found that the MRI is 100% sensitive, 90% specific, and accurate to around 97%. While the MRI is a great diagnostic tool, it still lacks sensitivity for detecting peripheral lesions when compared to the gold standard, obviously, of arthroscopy. If you can see here, you can see right here where it is highlighted white, where the arrow points, that is the TFCC tear on an MRI. So in summary, the TFCC is a complicated structure located on the ulnar side of the wrist, and it comprises of 8 individual structures. It is the main stabilizing structure of the ulnar side of the wrist and transfers about 20% of the wrist force across the wrist. A lesion of the TFCC rarely occurs in isolation, and short of arthroscopy, MRI is our best imaging study to evaluate a TFCC lesion. So, my best practice recommendation in regards to classification imaging is that classification scheme implies that a TFCC tear occurs in isolation. However, clinical studies have shown that multiple areas can tear in a single injury. Again, for imaging, short of arthroscopy, MRI is the best form of diagnostic imaging when evaluating TFCC lesion, but still has its limitations. And here are my references. And one more slide of references. Thank you so much. Have a great day.